Hello, everyone. Thank you so much for helping me. It's another day. My name is Ransom Nima. I'm a med student studying medical radiography and my third year, soon to join my fourth year med school. But I'm just preparing for exams because grades I will excel as well. So, and apart from my medical studies, I'm also a proficient medical writer. So today I have an amazing guest speaker. She's a medical doctor all the way from the UK. Hey, Dr. Lizzie, could you introduce yourself?
Morning. Hi. It's a pleasure to be here with you today. I am an A&E doctor working just outside of London. So I'm in the emergency department with anything and everything that comes in.
Yeah, emergency department is kind of like a very tricky profession. How do you choose that profession earlier? How did you get the decision to say, "Hey, I want to move into the emergency department"? What made you to do that?
So since childhood, I always thought I might end up in A&D. I just thought it was such an exciting place and it was where the most interesting and adventurous things in the hospital were happening. Kind of think imagining a hero on TV running into action. That just sounded like a great place to be. But I had doubts whether I would be able to, I almost think of it as hack the lifestyle, if it would work for me personally, night shifts, late shifts. But I was always interested in the work of saving lives.
Amazing, amazing. And emergency department is a very critical, place where a lot of patients with, diverse diseases and injuries come to. And I believe that you're doing a great job over there. Thank you so much for sharing that with us. So we have a couple of questions for you to answer. You ready?
Yeah.
So the first question is, what is the most common emergency situations you encountered or you're encountering in the emergency department, and how do you usually react to this situation? So tell us.
So you've got a lot of the dramatic that comes into A&E, so often heart attacks, things like strokes, but commonly you'll find things like falls and lots of elderly people falling over. Sometimes it's as simple as slipping out of bed, falling backwards. You have lots of infections as well from all sources. So those are the most common things that come in. Um, yeah.
So how do you react to these situations? What are your reactions towards these critical diseases and injuries you're faced with patients? To tell us how you do that.
So the common things, um, they're not always going to be so interesting and exciting. And I think that's one of the things about the emergency department. You will have lots of dramatic cases, quite a few dramatic cases that come in, but more frequently they won't be so dramatic. But you have to be cautious. So even when I think of the 80-year-old person who falls over, sometimes you might imagine there won't be many injuries. We can be quite cautious in a good way to make sure that we're not missing um, breaks or fractures. And so every time you see a patient, I think the key thing in terms of dealing with that is making sure that you're thorough, making sure that you're not dismissive. Even with infections, people can deteriorate very quickly, and making sure that you're getting started on treatment, antibiotics, you're starting them on the fluids. So it's being thorough kind of every time you see a person, not just thinking, oh, I know what's going on, I know what this is. It's just having your radar for when things or when conditions deteriorate. So you just have to be on the ball with that.
Wow, amazing. I'm a bit curious about something. Do you work with radiographers at the emergency department?
Yeah, all the time. We're always asking for scans, discussing scans, getting their input into what we're seeing on the scans. So we work quite closely with the people, especially in CT and X-rays.
Can you do without the radiographers in the emergency department? Is it possible?
Not at all, not at all. I request scans all day, every day, and frequently we have quite automated processes. You put a request in, but especially when things are more complicated, or you're trying to do or request a scan that's not quite in the box, you've got a suspicion of something, even you might not have all the evidence pointing towards it. It might be intuition, something a bit rarer, and so you're discussing those cases, discussing what's the best sort of scan for particular conditions as well. So there's a lot of teamwork that goes into between radiographers, radiologists, and
I
the.
mean, I know. Tumors are really acquainted with radiologists and radiographers, but there are different types of tumors. In my medical studies, we're taught about different types of tumors. I know I don't want to go deeper into that, but I want to know something, right? How do you determine about the most important scan needed? How do you know that this is the time to use a CT scan and the time to use an MRI, the time to use an ultrasound? To tell us how you do that.
um you can learn things quickly with experience, but also we have fantastic guidelines. So when we think about CT scans, or for head injuries or potential head injuries, we've got quite clear rules about when we should scan, within what time frame, and also when we don't need to scan and when we should do observations as well. We have to think about managing our resources correctly. It's not about scanning every single person who comes into the department, but also it's knowing that certain people are higher risks, where actually even if they present quite well, they have got high risk of deteriorating, so you might want to scan them earlier. Also, depending on the scan that you're doing, there might be some potential harms to people. We think about CTs and radiation. If a CT is needed, then yes, we'll go for it, we will advise it, but there will be definitely conditions where we want to hold back of that, and maybe just observe first and then make a decision about scanning a bit later.
Okay, before I move to the second question, there are lessons you've learned in the ED department, right? There are lessons and takeaways of acquainted from it. But before I go into the second question, I want to know something. In my later understanding of radiography, my third year, I noticed something. There are some slight mistakes that can happen during scan, running some radiations on patients, right? So I want to know if there is an error in a scan or in a radiation, whatever. How do you try to amend those slight mistakes? Because if you do that two times on a patient, it's an accumulation of more radiations on the patient. We could cause something deadly on the patient in time run. So how do radiographers, or how do you guys tend to amend that slight mistake rather than going over and over again on that scan?
When mistakes happen, I think it's really important to apologize, to be transparent about what has happened, and to also interrogate what has happened and how we can stop it from happening again. Medicine has developed over time. Things have gone wrong with the best intention before. We have more knowledge and growing knowledge. And I think we have to be honest about that. And so when mistakes have happened, why did this happen? Why did this happen in this case? And I hopefully with investigating it rather than just hiding it away or trying to pretend it didn't happen, we can stop it from happening again and take the learning points from there.
I understand. Firstly, when we're taught psychology and radiography, my previous lecturer, Dr. Tom Adejo, he talked about apologizing. That's why I was really amazed by what you just said. And apologize is not about just saying sorry to the patient. That draws us to one of the courses we're going to do in founder level, in few months' time, about research and methodology. How you try to the researches you've done, like the results you've done, which is very a big mistake or a slight mistake. You try to use your research skills to tell the patient, say, hey, this, that. So the patient won't see you as you don't know what you're doing. You do mistakes all over. So yeah. So that drove me to the second question. So can you share a specific problems or memories of working in the emergency department, and what is the most important takeaways or lessons you've learned from it? I know there are a lot that you just have to, be sure about.
Oh gosh, it's like, where do I start? Um, One of the things I think with the years I've been working is the ability to listen and the ability to work with teams very well. A lot of that just fits well under communication. That is being able to talk to your patients and find out the right and relevant information from them. That is about really listening out for their concerns and also trying to pull out what is most important for you in that particular case. So when you're doing your initial consultation, sometimes there's a tendency to want to move through it quite quickly. It's like, I have an idea of what's going on. They may have already had a bit of a triage, so there's a bit of a sentence or short paragraph about why they've come in. And so sometimes you can go in with a clear idea and then you hear what the other person's saying. And it's important to pick up exactly what it is, that has brought them in that day. And sometimes, when you have a bit of a fixed idea or a bias, it's easy to miss the other things around it. Um, and when, therefore, you have got that ability to listen well and hear well, you're more likely to get to the right treatment or to the right investigations first. So frequently people will come in with long-term issues. And then the question is, why have you come in today? What has changed today about your condition? And with things like that, with people who have lots of chronic bowel issues, one diagnosis that you don't want to miss is things like bowel obstructions, and those can come out quite sensitive. You have to ask the hard questions. You say, oh, but you've had this pain for a long time. By pulling out, interrogating and hearing quite quickly, that's when you can order the right test, like a CT, and then see, actually, you might need to have an operation today, or we need to give you some fluids and put a drip in, things like that. So it's the ability to listen very clearly, which can help and which becomes very useful. And then also when you're communicating what's going on, trying to get other teams on board. Depending on where you work, there can be some difficulties with the different specialties, because in emergency medicine we don't do everything by ourselves. It's frequently pulling in people from orthopedics, whether we're talking to the cardiologists, talking to the medics, trying to get people into intensive care. And so you have to tell your story or tell the patient's story in a way that gets that other person in and gets them involved. And sometimes people will almost want to be kind of dismissive as well towards you and say, oh, maybe you could deal with that. Are you sure they need to see me? It's kind of putting those key phrases and communicating, oh, yeah, they need to see you today. Please, can you come now? When are you coming? Trying to put that story together cohesively so that the other person listening on the other side of the phone can respond to it the right way. I just think of effective cases where people have deteriorated very quickly and we've needed intensive care then. And it's just trying to stress that, especially over the phone when they can't see the patient. We've got someone deteriorating. We need you now, please.
Amazing. That was an amazing answer on that question, Dr. Lizzie. Thank you so much for sharing that. So I know, forget about working in the emergency department. I know being a medical doctor is a very stressful profession. Let's be very honest with you. Um, so that draws me to this fourth question, right? Or the third question. So, how do you maintain the balance between providing prompt and effective care in a stressful situations and ensuring that all patients are assessed and diagnosed accurately? Because hey, there are patients that are not really easy to handle. They're so rude and stuff. So tell us how you do that.
I'm lucky for the team. I'm lucky that we don't have to work as doctors by ourselves. We've got the nurses, we've got healthcare assistants. The emergency department doesn't work in time order. We try and see the sickest people first, treat the one who's at highest risk of deterioration first, and get them started on treatment. And so the team works to try and identify those who are the most unwell. We have things like our observations, we have our blood results. And so we're able frequently to identify those who are sickest. But also, you have to have that awareness that some people will not present in a way that makes them appear particularly unwell. Think of the elderly, they can be more stoic. Sometimes, men and women will try to hide their pain. I tell patients, please, if you are in pain, if you're getting worse, let someone know, speak up, tell us as well. So we've got some objective parameters, their heart rate, their oxygen rate, which if they're low, if they're too high, we can identify that. But also it works on people when they can or trying to say something or speaking up. And also then for our healthcare assistants and other people who are with the patients, sometimes a bit closer, to try and spot signs of illness well as well.
I forgot to ask you a question. Wait, in the UK right now, no, you're not in the UK, in London. How is London's healthcare system right now? And what school did you study your medicine degree from?
So I went to the University of Nottingham. I've worked all over the country, around Leeds, around Cambridge. I'm now just outside of London, and it is tough. We have more numbers coming into the hospitals than the hospitals were built for, than the emergency departments were built for. And sometimes that means that physical space is a little small. But also that means as well that we have to continue to prioritize the most unwell patients. And so we can have very long waits. People may wait all night to be able to speak to a doctor and be discharged. We like to think that those who are waiting for all those hours are the ones who are able to do so. It's not nice. It can be very uncomfortable. We try to monitor people well. We try to be able to give them the initial treatment if those issues are identified, but there can be very long waits. It's it's not how we want it to be, certainly, but we still like to think we are running safe departments and the sickest ones are well looked after.
Oh, thank you so. That's why I said that medicine is a very stressful profession. You're really traveling all over the world, and you have a family. So how do you have time to take care of your family? So because I know you're very busy, so how do you find time to take care of your family, and then we'll go from there.
So it's my husband and I now. Um, but yeah, we think of ahead in the future when you might have more caring roles for parents, or when you have children. And I've got colleagues who do have children and other more responsibilities that I do. I think you have to be clear about your work. It is work when you're there, work hard, but also work shouldn't be everything, and cannot be everything. And so it's really important to build space for the rest of life, because medicine is something that can invade into all areas, that can take up all your time. But if you as an individual has other things which are hopefully more important to you, um, then you just have to build that into your life. And you have to build it with intention. If you can, find that time to plan as well. This is when I'm at work. This is when I'm not at work. And I think it's important to have those separate identities. Medicine is not my everything, but it is important.
Absolutely, absolutely. Thank you so much for sharing that with us. So the next question goes this way: what challenges or stressors do doctors face when working in the emergency department, especially in busy cities like London? Yeah, everybody knows that London is a very busy city. So tell us how, one of the, challenges doctors face, including you, and how they, survive from those challenges.
I think one of the hardest things is how to remain compassionate and kind over a long period of time when you're dealing with very, very stressful, and difficult and traumatic occasions for people. By that, I mean, there's been a number of times where I've had to break really bad news and tell loved ones, family members that their loved one is not going to survive. And there's been a catastrophe that they have already died in times. And you have to build up a level of resilience where you're able to share that news without breaking down yourself. It's not your trauma. But also, you don't want to become cold or become too desensitized to that as well. There's this balance where you don't take it all on yourself, the emotional weight, but also that you don't become too cold or hard. I think that's not an easy line to walk along. And part of that as well is because of the numbers that we see, a lot of them are in distress. We have a lot of patients. I think of the patients who've got things like dementia and some other mental health conditions. There's a lot of screaming that happens in the emergency department. I remember the number of times I've heard people shout, "Help me." And then we can sometimes really be screaming. Maybe they're scared or they're in a room by themselves. And when someone's shouting, "Help me," most kind people want to respond. They want to investigate. They want to, sorry, if someone's shouting, let's go and see. And then when you hear things like that a lot of the time, you realize actually it's not always that you do need to respond. And that's a really weird training that happens. And so if someone has got dementia, sometimes it'll be a case they just don't have an idea what's going on. Sometimes they'll have someone in the room with them, they've been looked after, and because, oh no, I just saw that person, or I just helped them, they are just shouting out. And so you've got to continue with your other work. You hear alarms go off all the time. You hear people in pain all the time. And you just have to learn which ones are appropriate to just switch off and trust that someone else is dealing with that, or it's not some abuse that's happening. And then other times you've got to be able to hear it and actually respond. It's not an easy thing to do. But I think that's one of the weird things about working in the emergency department, the amount of shouting, screaming that just happens around you, and then you just continue working. I think you're frozen. There's no sound. Sorry. I think you're on mute.
You can continue. I think we had a little um, internet, issues here, but you can continue, please.
Um, I think I was just talking about the times you hear people screaming or shouting out in pain, and where you have to trust that they're being well looked after. Mm-hmm.
Hello?
Hi.
I'm sorry. I thought we had a serial. We had an internet, you know, disruptions, but we're good now. Dr. Lisa, thank you so much for sharing that with us. Now you know the difference. You know, with Nigerians network. And but as well. So let's just move to the next question, right? So in your experience, right? What is the most important skill or quality that has led you to succeed as an emergency room physician? So tell us.
The ability to cope well with pressure and stress um, is something so important. When it can be very, very chaotic in an emergency department, you'll have lots of, let's say, egos, different specialties. You can have, looking for equipment, especially in critical moments. And often the role of the emergency department doctor is to be, we call a team leader, cases like trauma or with arrests, and the ability to absorb the scene and to direct people well and to manage that team and to be able to take in the information quickly as it comes. You might get a blood result and then being able to action on that. Um, that is what you want from someone in A&E. The ability to just stay calm in that and not to start becoming overwhelmed themselves, which is easy to do so when you've got cases where someone's dying in front of you. But just being able to almost bring a stillness to that team and help other members to feel like, okay, we know what we're doing and let's just sort out this condition, let's sort things out.
Amazing. These are amazing qualities you just shared right now. Thank you so much, Dr. Lizzie. So, there are new advancements in technologies used in the emergency medicine, right? So, what changes or advancements do you see in emergency medicine as a healthcare field, continues to evolve? So tell us.
Um, I am so excited about more and more automation coming into the emergency department to help us identify the sickest people faster and so that we can start interventions a lot quicker. I think of even like radiology reporting and some of like the AI's things which are coming through. We have got something in my hospital which I can be a bit geeky about. I think is really amazing. And so for people who have had a CT, the scan can be reported within minutes to get a result and say this person is more suitable for thrombolysis. These sorts of things coming into the emergency department where it's like this is the condition, this is how we can treat it within seconds, within minutes, is going to save lives and yes, bring people to more health, um, and also like the time to even get results. Blood results can take hours to come back as we're able to automate processes that can start to take minutes. We've got point of care tests, which we already have a few of them. Think of blood gases where you can get the results very, very quickly. But as we can increase the numbers of tests that we can do, it is definitely going to revolutionize things. People shouldn't have to wait in an emergency department for hours. Scans shouldn't have to take hours to be reported. As we can just automate those processes, then hopefully things will be done a lot faster.
Amazing, amazing. Thank you so much, Dr. Lizzie. We have the last question for you. You've been an amazing guest speaker thus far. Thank you so much for sharing your own narratives in these questions for the audience to get more enlightened on things related to emergency medicines and others. So thank you so much. So the last question goes this way. Now, in your own perspective, how do you think these will affect the way emergency services operates in the future using the latest advancement and changes in emergency medicine? So tell us.
I would love it if you could walk into a hospital within a few minutes, observations are done, your blood tests are done, you've got your ECG, they're already kind of telling you, do your sample here, let's take you for this scan. And within an hour or so, you can have the results. Doctors are best served when they can speak to patients when they can, I think, spend time with the patients. More and more, we seem to be caught up with more, I wouldn't call them admin roles. That's putting requests through, that's phoning different hospitals, that's a lot of arranging behind the scenes, which takes us away from patients and patient contact. As we automate processes, doctors will be able to spend more time with patients, actually seeing them versus arranging things for them. Same with things like some of our discharges. When we're trying to arrange follow-ups, it's emails that we're sending off. That's not time with patients. And actually, I think a lot of doctors want to be doing things for patients, whether procedures, whether consultations. So as we can streamline particular things, automate particular things, get results faster, then hopefully we'll be able to provide more care directly to patients. And that will just improve the service and also improve effectiveness of the healthcare system.
Thank you so much, Dr. Lizzie. We've come to the end of the session. You have a very tight schedule and had to honor my invitation by hopping in to, enlighten the audience. And I'm really, really grateful, and it's an honor to have you on our podcast today. So before we wrap up the session, what are your last words for the audience?
For those who are in medicine or wanting to be medicine, training within medicine, I just want to stress you need to be able to look after yourself well before you're looking after others. And the system, the healthcare system, can burn you out. The need is too great. It's too great for any one person, and often it feels like it's too great for the system. So you need to put things around yourself to make sure that you are staying healthy and well, and that will be one of the best ways to keep you in the profession over a long period of time, to maintain compassion and kindness for yourselves, to be able to give it and share it with other people. But yeah, best of luck. It is wonderful to be a doctor. I get so many highs with it, amongst the lows. I love being a doctor, and it's definitely something that I would recommend.
Thank you so much. So if you love this content, do well to subscribe, like, and comment to your network. And hopefully someone to your network will definitely appreciate this video. Thank you so much, Dr. Lizzie.
Thank you for having me. All the best. Bye.
All right, take care.